Hello, my name is Aurore Fraiture and I'm an anesthesiologist. I'm going to talk to you about shoulder analgesia and anesthesia. Being a good anesthesiologist is not only providing the best pace management for the patient, but also the optimal surgical condition for the patient, for the surgeon. Both arthroscopic and open surgery are known to be very painful, extremely painful for the patient. Before nurse blocks, it requires high doses of opioids like morphine, but morphine had numerous side effects, unwanted side effects, like vomiting, sedation, hyperalgesia, and hallucination. Thanks to nurse blocks, clinicians now can send the patient back home on the day of the surgery, pain-free, and without any opioid side effect. How do you execute a perfect nerve blocks? First of all, you need to know the anatomy. The brachial plexus innervates bone, joints, muscles, and skin of the upper extremity. Its main route goes through the neck between the anterior scalene and the middle scalene muscle. This is the place to perform the interscalene block. The interscalene block is indicated for all procedure on the shoulder, on the proximal humerus, as well as the lateral two-thirds of the clavicle. The interscalene block is indicated for shoulder surgery, proximal humerus, as well as the lateral two-thirds of the clavicle. How do we proceed? It's an ultrasound-guided technique. It's conducted on an awake patient with a routine monitoring. The patient has an IV, peripheral IV access and oxygen. The head is slightly turned on the opposite side, so we expose the neck. Everything is ergonomically arranged to facilitate the needling and the scanning. We can draw a line between the ultrasound machine, the patient, and the anesthesiologist. According to the type of the surgery, we can do a single injection or we can place a catheter to deliver continuous infusion of local anesthetic. Why we will choose a continuous catheter infusion? To extend the efficiency of the block. The catheter stays in place for 2 or 3 days. The patient can be fully ambulant while using a small elastomeric balloon pump or an electronic pump. The catheter, the continuous catheter infusion, should be considered for every invasive surgeries. What kind of drug are we using? There are many local anesthetic drugs. We select the drugs based on the desired duration and density of the block. The most commonly used is the ropivacaine, 0.2%. The low concentration of the ropivacaine avoid prolonged monoblock when we use it in the continuous infusion. In knees, the standard output is 5 milliliters per hour, and the patient can have an additional 5 milliliter bolus every hour if it is painful. But there is some complication, and you need to be aware of them so you can recognize them and react. One of the complications is the hoarseness. The hoarseness is due to the blockade of the recurrent laryngeal nerves, which occur more frequently on the right side. Be careful, because if the patient has an existing vocal cord palsy, he could have a complete airway obstruction. Another complication is the Aurore syndrome. The Horner syndrome is characterized by ptosis, meiosis, and enophthalmia. The reason of this complication is the spread of the local anesthetic around the anterior scalene muscles. It will block the cervical ganglion. The patient should be instructed on the occurrence of this complication of this syndrome and reassured about its benign nature. In this area, there is another one, the phrenic nerves. The phrenic nerve is also located in this area, and if it's blocked, it will result in an hemidiaphragmatic paresis, which is a substantial risk in patients with severe pulmonary pathology, because it can lead to a 25% reduction of the pulmonary function. The last one and the worst one is the systemic toxicity. It's very rare, but you need to know it. The systemic toxicity is due to the absorption of local anesthetic. The severity depends on the doses, but most commonly, it is caused by an unwanted injection, intravascular injection. The symptoms are perioral numbness, tinnitus, agitation, dysarthria, confusion, seizure, coma, and cardiac arrest. So all these complications are rare, but you need to know it to react. Now, about the intraoperative management. Shoulder surgery can be performed in two positions, the beach chair position and the lateral decubitus position. We prefer the beach chair position as a reliable, a safe, and an effective position to perform nearly all types of procedures. The trunk and the head are raised to an angle to 20 to 30 degrees to reduce the venous pressure in the shoulders. Raising the legs will help maintain the cardiac output and the venous return. The legs are flexed to avoid the overstretching. And the neck and the head are carefully secured to avoid the overstretched plexus, brachial plexus. But the patient in the beach chair position are prone to hypotension, mainly due to the pulling in the extremity, venous pulling in the extremities, and the lack of surgical situation due to an effective block. Shoulder surgery can be performed under regional anesthesia or associated with a general anesthesia. Which technique should you use? The choice between these two techniques depends on many factors, including patient and the surgeon's preferences. General anesthesia provides a complete control environment, security, with muscles relaxation and control hypotension. Sometimes surgeons ask for it, because control hypotension has been used to provide a satisfactory bloodless surgical field. But there is controversy about it, about the control hypotension in the beach chair position, because it's rare, but some neurovascular injuries have been reported. So blood pressure must be carefully monitored during general anesthesia in the beach chair position, as well as the saturation, the cerebral oxygenation saturation with new techniques like the NIRS. The NIRS is the near infrared spectroscopy to control the cerebral oxygenation saturation. We have new techniques. We need to use it to improve the safety, security of general anesthesia and other. Personally, I'm a huge fan of clonidine. Clonidine and dexmedetomidine are both alpha-2 agonist receptor with a direct peripheral vasoconstrictive effect. This is a bonus effect that improves the surgical condition in arthroscopy. But these two drugs have many other well-established roles in acute postoperative pain management by preventing the transition from acute to chronic pain. So the drugs used in these are the remifentanil and propofol for induction, intubation, and sometimes neuromuscular block. The maintenance of the general anesthesia, for the maintenance of general anesthesia, the sevoflurane use. And I use clonidine. So there is many significant advance in the management of anesthesia and analgesia for surgeries. All we desire is the best for the patient. Thank you.